morning, everyone. We're really excited to be participating in our Best Practices Conference this morning, and our speaker will be Captain Larry Alonso. The session is expanding access to the National Diabetes Prevention Program, increasing opportunities for all of Indian country. Captain Larry Alonso is a commissioned officer of the United States Public Health Service, serving at the pleasure of the U.S. General Surgeon as a board certified service, serving and as a family nurse practitioner. He's a board certified family nurse practitioner stationed at the U.S. Centers for Disease Control and Prevention in Atlanta, Georgia. Captain Alonso is currently assigned to the Tribal, Region, and Territorial Team of the Divisions of Diabetes Translation as a project officer, where he assists American Indian tribes with type 2 diabetes prevention. Captain Alonso has deployed in both direct care, emergency response, and team roles. Captain Alonso received his bachelor's in education from the State University of New York at Cortland in 1988. So we can see he has a lot of experience there. He has a master's degree from the University of Tennessee. Prior duty stations include the Indian Health Service, New Mexico, Centers for Medicare and Medicaid Services, San Francisco, and Federal Bureau of Prisons, Colorado. His public health career spans 30 years, having served in both federal and state public health settings. We really are very honored to be able to have Larry Alonso working with us today and presenting. We here at USET have the pleasure, and I mean it really is a pleasure, to work with him as our project officer for the Good Health and Wellness in Indian Country project. So thank you very much, Larry. I'm going to leave it and turn it over to you in just 1 second. I just wanted to let people know a few things. The presentation will be available after the conference, so you'll be able to do this. You'll be able to ask questions at the end of the presentation. And if you have questions, you will be able to type those questions in the chat. I believe I covered most of the information. My co-moderator is Jasmine Alvarado, and she will also be keeping us informed, and she will, when you type in things in the chat, she will be able to respond to those things immediately. Thank you and welcome.
Well, thank you, Pam. You made me break out into a sweat here first thing in the morning with that introduction. And welcome everybody. Man, I'm so grateful and honored to be here. I'm going to go ahead and immediately start sharing my screen so that you can see, we can get about the business of learning what it is. I have some cool things to share with you, some very exciting things to share with you. So let me go ahead and pull that up. All right, Jasmine, give me a thumbs up if you can see my screen. Awesome, 2 thumbs up, that's awesome. All right, hey, good morning, everybody. Thank you for the invitation and the opportunity to speak with you. The only thing better would be to see y'all in person, because I'm a hugger, right? And both my parents are from Puerto Rico, and the family get-togethers are just, you know, hug fests. So I would love to see you in person, but the days and times don't allow that, so I'll have to transmit that through the screen somehow. Thank you for the opportunity to speak with you. I have about 50 minutes to present and then answer any questions that you might have. If I can answer questions, I will live. Otherwise, I can take questions back to the team that I'm with at the CDC's Division of Diabetes Translation within the National Center for Chronic Disease Prevention and Health Promotion. So I'm going to do my best to cover the National Diabetes Prevention Program kind of as an orientation, and then drill down a little bit to tell you how we're trying to expand access to the National Diabetes Prevention Program. And hopefully by the end of this, two things will be true. One, I will transmit to you a thank you, and I'll do that now. You know, I am so grateful for everyone, for each of you who's on the line. You are frontline workers in public health. Without you, what I'm going to talk about today is a car with no gas. I am a nurse practitioner, as Pam said, by training. I've worked on the Navajo reservation. I have held the cellulitic foot. I have held in my hand the lab results announcing, the unwelcome news of type 2 diabetes. I have seen diabetic neuropathy, nephropathy, retinopathy happen, and all of those things tear at me, and medicine is important. But what I'm talking about here is changing the conversation for future generations so that instead of talking about diabetes and medicine, we're talking about hey, I ran that 5K. I walked that 5K. I'm still, still about looking about the same as I did when I graduated high school, or measures of health rather than topics of illness. And between what we know and our patient base, you guys are there making this happen. So I want to thank you for the work that you're doing. Your work matters. It's, of course, supremely important. And what you learn as you take this information and bring it to your communities matters as well. It matters to us. And that will become more apparent as I go into the presentation. The second thing I hope that you take away, first is a thank you and just a profound gratitude to you. Second thing is I want to frame everything I say in terms of there is an evidence base here. That evidence base has translated into massive disease prevention with regards to type 2 diabetes prevention. And so the context here is we want to hold as close as possible to the evidence base so that all of our community members who participate in this National Diabetes Prevention Program will derive the same benefit that the research says lies within the intervention. That's a 58% reduction when people follow that year-long lifestyle program, that National DPP Lifestyle Challenge Program. 58% of the people in the original study were prevented from moving from pre-diabetes to type 2 diabetes. So if we stick close to the evidence base, then we can reasonably assure all of our patients who are benefiting from this year-long program that they too will benefit from those kinds of outcomes. Okay, so I'm going to have slide boredom here. Okay. Experiencing some technical difficulties here. My slide is not advancing. Let's try and do it again. Hang on, y'all. It's technology time. Okay. All right. My slides are not advancing, Jasmine. Let's try it again. This is the fun of virtual presenting. I'll form a little bead of sweat here in a minute. Let's see here. Hold on. Hold on. Okay, let's try that. Yay! Recovery. Okay. All right. So let's first of all talk about the scope of the problem. So pre-diabetes, right? So in the context of good health and wellness in Indian country, we ask basically in that strategy 3 that we want to encourage all of our recipients, all of our good health and wellness in Indian country recipients to do 4 things. One is to increase awareness of prediabetes amongst our community members and our providers, because not all providers are frosty on prediabetes. All right. So we want to increase awareness. We want to increase screening for prediabetes. For the purposes of referring to a CDC recognized type 2 diabetes prevention program. I'll talk a little bit more about that later. And then the fourth thing is that we would love for this to be adapted so it resonates culturally within the setting where it's being delivered. This is the cultural modifications, right, of the National Diabetes Prevention Program. If this program is delivered and it feels like it was really made for someplace else, then it's not going to have the traction. It really, and there's so many ways to adapt this so that it really reflects the values and the norms and the traditions and the culture of the community where it's being received. So prediabetes, 88 million, right, 1 in 3 prediabetes, right, more than 8 in 10 don't know they have it. That's why we're looking at wanting to encourage increased awareness. And then, you know, what prediabetes is, right? Blood sugar levels are higher than normal, but not yet high enough to be diagnosed with type 2 diabetes. What does it put you at risk for? The same thing that it puts you at risk for type 2 diabetes, heart disease, stroke. We call it target organ damage. All right, moving down the slide deck here. So, you know, the cool thing about prediabetes and the specter that represents, you know, for many generations, is that we have an intervention that's proven to work. So evidence from the Diabetes Prevention Program research trial and similar studies that have been conducted all over the world have shown us that participation in a structured year-long lifestyle change program can dramatically decrease the risk for type 2 diabetes in adults who are at high risk. So in the US, this work began with the Diabetes Prevention Program clinical trial in 1996. And in that Diabetes Prevention Program, DPP, adults with prediabetes were randomly assigned to one of 3 intervention arms. First, that year-long lifestyle change program. Second was just metformin. And third was a placebo group. And so participants in that lifestyle arm lowered their risk of developing type 2 diabetes by 58%. Even higher if folks were over 60 years old. It was 71%. And that was compared to 31% in the metformin group. So we have something that really works. I'm going to digress for a moment here. Let me just move down here. Okay. So here's the thing. American Indian and Alaska Native people contributed to building this evidence at all levels, from participating in the original DPP research trial to helping to translate the research findings in real world settings through the Special Diabetes Program initiative, so the SDPI. I'm going to stop here. There's a lot of confusion about the national DPP and SDPI. The easiest way I can talk about this is SDPI is a congressional funding source, and it is a community directed. Many of you know this, right? Community directed. When those monies come from the Indian Health Service to the tribes for SDPI diabetes prevention work, the community decides how to spend those dollars. So that is a funding source in order to accomplish diabetes prevention. The national DPP is a tool that hangs on the pegboard that you may or may not use depending on the community, right? So you can decide to use SDPI dollars to implement the national DPP or not. The SDPI may be focused on other diabetes prevention work. So I just wanted to differentiate SDPI as a funding source, community-directed diabetes prevention kind of globally versus the national DPP, which is a tool that can be taken off the pegboard and used and paid for by SDPI, but doesn't have to be. Okay, so the Diabetes Prevention Program study findings that were released in 2002 included 171 American Indian volunteers, which was a clear message that this program has applicability, has relevance in American Indian communities, whether that's reservation communities or whether that's urban Indian health centers that are serving American Indian people within urban settings. So by 2004, the special diabetes program for Indian was set to demonstrate the diabetes prevention program in tribal communities. And in 2010, the CDC was charged by Congress to establish a national program of partnerships that were working together to establish that to help all Americans prevent type 2 diabetes. That national program is the National Diabetes Prevention Program. All right. So that's what that, and by 2012, that Diabetes Prevention Recognition Program, that DPRP, the recognition program, which is an arm of the National Diabetes Prevention Program, and it's the quality assurance arm. It's the arm, the Diabetes Prevention Recognition Program, housed at the CDC. It exists to ensure that the quality standards remain intact so that anybody who goes into the program or participates in that year-long program is reasonably assured to have the same benefits, same outcomes as the original research. So that's kind of the big deal. In 2019, the CDC established a cooperative agreement with the Choctaw Nation of Oklahoma. I'm the project officer for that, to develop an umbrella program. This is a part of increasing access. I'll unpack this a little bit later. And I'm happy to say that Choctaw Nation's now in their third year of deploying that umbrella to demonstrate how a regional hub could relieve the administrative burden for smaller tribes who are participating in the CDC recognized lifestyle change program. The new 5-year cycle of GWIC, which is the cycle that y'all are participating in, provides resources to 27 recipients, that's both tribes and tribal organizations, chairman's health boards such as USET, to expand access to the CDC recognized programs in tribal communities, in both urban and rural settings. Okay. So what we're looking at here is, this is a response to the critical public health need, right? We understand that that type 2 diabetes is a public health threat. It's epidemic, and this is a proven intervention to reduce the burden, to prevent type 2 diabetes. Congress authorized the CDC to establish that National Diabetes Prevention Program in 2010. And we're working with partners across many sectors, including healthcare, community-based organizations, insurers, businesses, like many others, to build an infrastructure for nationwide delivery of this effective evidence-based lifestyle change program for adults with prediabetes. Two important words there. For adults, this is not authorized for children, although we don't want to neglect the children, but this program specifically focuses on adults and with prediabetes, not with type 2 diabetes, with prediabetes. Okay. The Lifestyle Change Program is a year-long, right, that's intervention that's designed to help participants lower their risk for type 2 diabetes through healthy eating, increased physical activity, and stress management. It's a year-long, so people are like, wow, that's a long time. It is a long time. It's a big commitment. A couple of kind of caveats here. It's a big commitment. A year is a long time. But here's the thing: is that type 2 diabetes, right? If that's an impending threat on health, this is what it's going to take. This is one solution that's a proven solution. It's going to take to kind of turn the ship around. It's hard. It's a big commitment. But type 2 diabetes is a big commitment. Taking medicine every day, measuring blood sugar, right? And then, God forbid, dialysis and, peripheral neuropathy and, blind. Those are big commitments. Here is something that is a big commitment, but it's a commitment that you can make to help stop this disease in its track. And it takes a while to affect behavior change. If you ever try and go on a diet, it takes a while before those behaviors, those new behaviors, become the old behaviors. Those new behaviors become kind of, that's how I live and I roll now. Okay, so moving down. Rolling along, my timer just went away. Give me a moment. Okay, here we go. Just want to keep honest on my time. All right, so moving down. So this National Diabetes Prevention Program has kind of 4 pillars. It's you know, when you talk about the National DPP, most people think about that year-long lifestyle change program. Other parts of the National DPP, the National Diabetes Prevention Program, include that Diabetes Prevention Recognition Program that sets the standards, that kind of tries to ensure fidelity to the original program. That's responsible for the standards. I'm going to talk a little bit about those standards. Those standards are updated every 3 years, and right now we're engaged in tribal consultation, big T, big C, you know, in speaking with tribal leaders in venues to solicit input. And today I want to invite you also, I'm going to give you the link. If you have suggestions for these new standards, to please send them to us through the link that I'll provide at the end of my presentation. The Lifestyle Change Program is a year long. Folks learn about making lasting lifestyle changes. I told you the focus is on healthy eating, physical activity, and stress management. Research has shown that for those folks who achieve at least 5% weight loss, they reap the greatest benefits. What we have seen is that we've done longitudinal follow-up studies that when folks lose 5% after the year-long National Diabetes Prevention Program, if they have lost 5%, then there's incredible hang time with this, that there's durability. People remain free of prediabetes because that change was so established in their lives and their thinking, but the folks who have a 5% weight loss really reap the biggest benefits. That's what the research showed and continues to show. I'll talk about some changes that are proposed that are evidence-based coming, and good news for folks in a little bit. The quality assurance arm, the Diabetes Prevention Recognition Program, that provides support to all the recognized orgs. An organization applies for recognition through the CDC, simple online application. And once they are given pending status, they're approved to begin participating, they're effectively in the stream of evidence, the stream of information that comes out from the CDC to try and keep folks apprised of updates and evidence-based changes, additions. So recognition is a really desirable thing to apply for and to receive. So the CDC's Diabetes Prevention Recognition Program, or that DPRP, administers a set of quality standards, and we refer to those as the DPRP standards, right? And that DPRP provides technical assistance through a bunch of different mechanisms, including webinars and a customer service center, various ways to support people out there who are trying to run this program, trying to offer this program to the community. The CDC maintains a registry for all recognized organizations. It ensures quality by recognizing organizations that are able to deliver the lifestyle change program effectively and achieve the outcomes that are proven to prevent or delay the onset of type 2 diabetes. It ensures organizations are offering an approved curriculum. You guys, you may be familiar with the Native Lifestyle Balance Program, which is nearly an approved curriculum. It's just it's just a 16-week, and so with some additions to increase its length to a year, the Native Lifestyle Balance Program could be an approved curriculum. But the CDC offers a free curriculum called Prevent T2. There are a couple of other curriculums that are approved. There are some that have been adapted with American Indian images and diets, specifically from the Northern Great Plains. But the CDC definitely encourages adaptations of the existing curricula so that there's resonance within the community. And the other thing that the registry does is it tracks attendance and weight loss as outcome measures. All right, moving down, just go through this kind of quickly. So there's lots of CDC recognized organizations across the United States, probably 1,700 now, and there's there's probably over 500,000 people who are enrolled in the national DPP. And this is, so this was as of July. It's probably more now, although COVID has impacted that. All right, let's talk a little bit about type 2 diabetes prevention in Indian country. Here's a little picture of the Missouri River close to the Santee Reservation. And it just shows a little timeline, the balanced budget amendment that passed, that initiated established the SDPI, and then the landmark DPP study. These things I've already mentioned a little bit, so I won't spend a lot of time, but moving across the timeline to 2019, what I want to convey to you by this slide is that you and the work that you're doing, you're right on the cutting edge of impacting the conversation about type 2 diabetes now and for future generations. So you see 2020, right? I am presently involved with Choctaw Nation as they are deploying a new approach to really reduce the barriers to the diabetes prevention recognition program. We'll talk a little bit more about that later. It's kind of the topic of the conversation. This is just a little picture of number of tribes that are fully recognized, preliminary and pending. 55 tribes and tribal organizations across the U.S. currently recognized by the Diabetes Prevention Recognition Program. And then let's talk a little bit about the new standards. These standards will be published in February of 2021. So recognition, what is it? Okay, we talked a little bit about this. Involves assuring quality, a quality assurance arm, by developing and maintaining a registry of organizations for their ability to achieve outcomes proven to prevent or delay the onset of type 2 diabetes. I'm going to stop for a minute and kind of look at, just kind of say this, we acknowledge at the CDC that there's diabetes prevention work going on and it's been going on for decades in American Indian communities. In many ways, the diabetes prevention work that's been going on in American Indian communities is setting the bar for communities all across the nation. I mean, but when we speak about diabetes prevention at the CDC, we're talking about the diabetes prevention, National Diabetes Prevention Program, which could include at the community level, the diabetes prevention at the community level could include the national DPP, but there's also other diabetes prevention work that goes on in the communities. And we recognize that that's effective work. The researches and the articles that come out speak to reduction in end-stage renal disease, reduction in type 2 diabetes. So there is effective diabetes prevention work going on. But when I'm speaking to you, what I'm speaking to you about today is the national DPP, that year-long program, and the recognition program, which sets the standards so that there's adherence to the evidence base. The quality standards here, those are those DPRP standards that are going to be changed in February 2021 with some exciting new things that are coming on board. A registry of organizations and data systems, the data that's submitted, classroom attendance, weight loss, those two primarily, A1C for those who are going to track A1C. So, but really the two big drivers for data are classroom attendance and weight loss, diet logs and exercise logs as well. Okay. So the 2021 proposed standards revisions, we're proposing some revisions to the current standards, the Diabetes Prevention Recognition Program standards. Those proposed changes are based upon evidence from published literature, existing data from Diabetes Prevention Recognition Program, and input from tribal programs and other key stakeholders across the country. So this is why I'm saying to you that what you see in your community as you deliver the national DPP really matters. What you do really matters. The information, the feedback that you provide to us really matters. It's going to be informing the changes of the recognition standards moving forward. We are engaged in tribal consultation, government to government relations with tribes and tribal organizations, with the CDC's Tribal Advisory Committee, IHS Tribal Leaders Committee in March. TAC meeting was canceled, but we have met with TAC leaders. We've published proposed revisions to the Diabetes Prevention Recognition Program standards in the Federal Register. That's still open for comment, and we've sent Dear Tribal Leaders letters out to for inviting comment as well. Some of the proposed changes: organizations can continue in pending recognition. So the way that this works is an organization who wishes to become a recognized organization gets online, fills out the online application, and when they submit that, they immediately receive a pending status. That means that they are recognized as a pending organization, so they can at that point begin to submit for reimbursement from Medicare. And so the pending recognition is a valid recognition. It carries the weight. The change that we're proposing for 2021, my stopwatch keeps going off, Jasmine. I'm trying to hold on one second, please stand by. Okay, 28 minutes. So the change that we're proposing is that as long as a organization that's in pending status continues to offer the program, submit data, they will continue to be in pending recognition status. That's different because before it really depended on was there a cohort of 5, was there 5% weight loss? No. What we're proposing is that as long as an organization continues to offer the program and submit data, they will retain their pending status. Preliminary recognition is also proposing. We're proposing to change that, where if an organization is preliminary recognition, what's the difference between preliminary and pending? Preliminary is that an organization has submitted their data for a cohort of 5 people over a course of a year, so they're more established than a pending organization, and that a preliminary organization can achieve preliminary when they retain at least 5 people and 5 people complete the year-long program, and those 5 people who attend at least 8 sessions in the first 6 months. And there's some other criteria, and if you want more information about this, I'm happy to provide it for you. Full recognition. I'm going to direct your eye here to the second bullet. Here's the really exciting thing. For recognition previously, it really depended on a minimum of 5% weight loss after 12 months, because that's what the evidence suggested. If someone loses 5% of their weight loss over 12 months, they will see that same reduction in progression to type 2 diabetes. That's what the evidence said. But we're gathering more evidence. We're receiving feedback, and we're evaluating that. So now we're proposing to add to those recognition standards not just 5%, but if there's a combination of a minimum of 4% weight loss and an average of 150 minutes per week of physical activity after 12 months, that will also count towards recognition. And what we're saying here is, one, the evidence supports this lower weight loss with the physical activity, because we recognize that scales can be stubborn, right? Not everybody loses weight the same. So, we're lowering the weight loss and incorporating the physical activity. Or if there's a 0.2% reduction in A1C compared to a baseline value, that also will count towards achieving recognition. So those are some big things. People from all over the nation are saying, hey, 5%, is not the only quantitative data set that is indicating success in this program. We've got people feeling well. We've got people who have lost 4%, but they keep exercising, and their depression is lifting, and the evidence supports this. So we're moving to change this. This is a proposed change, as well as a 0.2% reduction in A1C. All right. So moving down then. So this is another proposed change to the standards that to acknowledge and support organizations that are able to maintain really good participant retention, that everyone who enrolls really hangs in there for the full year. Full recognition is possible for a 2-year period of time if a minimum of 50% of the participants if there's a minimum of 50% participants at the beginning of the 4th month, and you can see the standards there. This is just to acknowledge a good job in retaining participants. If an organization shows strong retention at 3 months, 6 months, and 9 months, they'll receive an extension of their full recognition from 3 years to 5 years. And I think I misspoke. I think it is, and I'll have to double check on this, that it is preliminary and full that is able to submit for Medicare reimbursement. If there are questions about that, I will get definitive answer for you. All right. How are we trying to reduce the barriers to encourage folks to participate in the diabetes prevention program? What do we recognize that there are administrative barriers. It's a heavy lift to offer a CDC recognized diabetes prevention program. Can be daunting. There's lifestyle coaches, there's the curriculum, there's collecting the data, there's submitting the data. Not everyone's got the FTE and certainly maybe not the expertise to offer this. So the CDC has recognized that, and we are trying to work with, specifically Choctaw Nation, but now through Good Health and Wellness in Indian Country, we're really trying to create and offer an umbrella option. What is this umbrella option? To break this down simply, an umbrella is you have an organization that, let's say they have experience in offering the National Diabetes Prevention Lifestyle Change Program. And you've got smaller communities, smaller tribal communities that maybe won't be able to find 5 people to participate. So they wouldn't be able to establish their own recognized program independently. Maybe they don't have the FTE staff. Maybe they don't have someone who really can be dedicated to collect the data, right? Well, those smaller communities, tribal communities, can join the umbrella with an experienced provider of the national DPP, aggregate their numbers with other tribal communities, and now you've got aggregated data, so you're not struggling to achieve 5. You've got 3 from one tribal community, 2 another 3, another 4. Next thing you know, you've got 12 folks who are in aggregate underneath the umbrella. And if the umbrella organization is recognized, then they extend their recognition to the smaller communities, and those smaller communities can borrow that recognition, can use that recognition to then bill and to participate as a recognized tribe. So they are recognized in aggregate. That's an umbrella organization. The umbrella organization that the hub of that umbrella organization is available to provide technical support, perhaps offer lifestyle coach training to help facilitate the groups that happen, because the secret sauce of this national DPP is the relationships that form between the participants at the community level. And as those participants learn about how they're going to change their lives with diet, exercise, and mindfulness, as they learn that, really to be able to talk about their shared journey is what fosters the success of the program. Well, there's a need there for a facilitated conversation. The hub can provide support, lifestyle coach training, so that there's a lifestyle coach in the communities who can facilitate those discussions and foster cohesion between the participants. And so that's the way a hub can support all of the participants within the umbrella organization. And hopefully that, and what we have found through Choctaw is that we asked them to have 2 or 3 participants in their umbrella, and they have 6, and with more knocking at the door wanting to come in. So this has been demonstrated to be a very successful model. We're not in this alone. We've got an umbrella hub that serves as a technical assistance center, and we've got other tribal communities where we can share the experience. So that's the umbrella organization. Hopefully I explained that well enough. And here's the thing is that a hub doesn't need to be an experienced provider of the national DPP. They just need to be willing to gather and aggregate the data and send that data to the CDC. Again, weight loss and classroom attendance being the 2 primary data points that will be submitted. So you don't have to be a expert provider of the national DPP. It certainly helps, but there is room to build the plane as you fly for a hub who's got the FTE power to kind of devote to this. So that's one way that the CDC's Division of Diabetes Translation is trying to reduce barriers to participation in the national DPP, recognizing that not every tribal community is going to have the FTE power or even the number of participants to apply for recognition on their own. Well, this is a way for them to participate and to avail themselves of all the goodness that is contained in the National Diabetes Prevention Program. Okay. So I'm at 38 minutes. I want to invite you to, this is the link to the Federal Register notice where you can submit. It says that the comment period ended September 14th. I believe that the comment period is still open. I will double check on that. Even if it's not open, if you have comments, suggestions, criticisms, gripes, laudatory comments, I would love to hear from you saying, what is it in particular that's getting in the way of your community offering the diabetes prevention national DPP lifestyle change program? I'd love to know, because if we don't know, we can't help to provide solutions. I forgot one key thing. I'm at 39 minutes. I'm going to take just a couple of minutes to talk about another innovation that's unfolding even as we speak. It's just about 4 months old, and that is the Distance Learning Center, the Coordinated Distance Learning Center. This Coordinated Distance Learning Center, this is, if there's a silver lining to COVID, and I say that with humility because I understand that people have lost loved ones and have become very sick, but there's been some things that have come about as a result of COVID, and one of them is that the virtual meetings and the power of virtual healthcare and even virtual public health care, such as we're doing now. The coordinated distance learning model is this, that we receive feedback that folks say, I want to participate in this national DPP, but the only time that the class is offered is Wednesdays at 5 o'clock, and I'm working, an afternoon shift, so I can't participate. So what we're looking to do, and which is it's already afoot, is the Choctaw Nation is going to be and has already established their website with a community calendar where there is going to be links where folks can click on a link and join a class so that they can get the content of the National DPP Lifestyle Change Program. So that's one session a week for 16 weeks, and then one session a month for the remainder of the time, for the remainder of the year. So let's say somebody wants to join on and say, I'd like to participate in this, but I can't make Wednesday at 5. If they go to that community calendar, they can click on a number of different session 1 sessions that are being offered all across different time zones, and even some that have been recorded, so that they can participate virtually